All right.
All right. So we are going to talk about the lockbox pilot that has been started in May of 2020, which Andrea and others have really made happen through the United Way. And there are lots of different partners that are part of that. But I am going to share my screen and just kind of give you a perspective from the Institute of Living and as a direct service provider, what it's been like to implement it. And I definitely want to recognize my colleagues, Ashley, who is on the call, as well as Marissa, who's provided a lot of support for the lockboxes. So I've never shared with Teams, so we're going to see how this goes. I'm not a Teams person. I am a Zoom person, but we're going to see how this works. So Andrea, let me know if you can see this.
Something's happening. Yes, we can.
Okay, awesome. I love that when that happens. Okay. So, this is actually a presentation that Marissa had me do to just update our operating committee last month. And so I just made some edits and just wanted to share with all of you and really welcome a discussion after I'm done. And if you have any questions or concerns as I go through, please let me know. So
Patty,
the lockbox, yes.
Could you maybe share it in presentation view so that it's a little bigger for folks?
On my end, it's showing presentation mode.
Oh, interesting. Okay. Is it just me that is seeing it in okay, so we're all seeing it in preview?
Okay. Well, let's try this again. How's that? If not, I'll just make it bigger.
Yeah, it's not switching over for some reason.
Okay. We'll just do it this way then. Sorry, everyone.
Can folks see it?
Is that a little bit better, everyone?
Yes, thank you.
Okay.
And I think if you hide participants and shrink your presenter group, then you should be able to see it maximized.
Okay. All right.
There we go. Thanks, Patty.
Yep. All right. So, yeah, I'm just going to talk a little bit about the lockbox pilot and just want to share that we really just started it as I work in child and adolescent PHP. So we get a lot of the teens from inpatient or even from the community or the ED. And, you know, we send them home every day. And so when I saw the notification back in, I think it was February or March, and was like, this is great. We should have this. And that's really just kind of how we got started. And then it blossomed, and you'll see how it blossomed in our system. So in our organization, we often start with patient stories. And so I think this is also really important. So we had a 12-year-old who was in our extended day treatment program in end of 2020. And then can you guys still hear me?
We can now. For a moment, it paused.
Okay. So this teen had a lot of familial challenges. There was just a lot going on in the home. And so per our standard work, we provided the counseling on access to lethal means and provided lock boxes at the intake. And so I mentioned this because the lock boxes are great. Most people in our organization here, oh, you know, the IOL and our colleagues are just giving out lock boxes. And the biggest message we give is it's not just the lock boxes, it's that we're having conversations utilizing the counseling on access to lethal means with these families and the teens as well about safety. And so this teen actually did break the box because the box was just sitting out on the kitchen counter. And while the box is great, it's not heavy duty or anything. It's just another safety measure. And so this teen did break the box just on the kitchen counter and did attempt via overdose. Thankfully, this teen did get to the emergency room, was able to be okay, and was able to re-engage in treatment. So when we found this out in our program, we actually were like, I wonder how much it takes to break one of these lock boxes. So we actually did an experiment, and it took just 2 whacks on a corner of a piece of cement or counter, and this is just what it looked like. And so it just reinforced the story that the lock boxes are a great pilot. It's a wonderful resource, but really counseling on access to lethal means and the discussion that you have with these teens and families, or any individuals, even adults, is the really important message that we wanted to share. So, most of you know, I think, about the pilot, but certainly this came through the Connecticut Suicide Advisory Board and the Committee on Reducing Access to Lethal Means. There's funding for the lock boxes, and it was really a pilot. I think that was meant to be a couple months or maybe a year, and it is in conjunction with the CALM training. And the recommendation or what's needed every month is we report on demographic data, not only of how many lock boxes are given, but also how many families are we talking to with the counseling on access to lethal means. Also recording those who say they don't need a lockbox. For a lot of families, they say we already have one. We got one in inpatient. We got it from the ED. So it's more of a conversation about that. So these are all of the areas in the state who are engaged in the pilot, which is phenomenal. And it actually wasn't until Marissa and I were working on this presentation that we found out that our colleagues over at Natchog Hospital in our large system are part of this as well. And so even in a large system, sometimes we're not always sure who's engaged in these larger state initiatives. So this is what the lockbox is actually supposed to look like. It's about 5.5 inches by 7.5 inches or so. We give out as many lockboxes as needed for the families. So there's no, they can only have 1 or 2 or anything. And the conversation that we have in our child and adolescent day treatment program is not just about the prescribed medications, but is also about any over-the-counter medications, any sharps, anything like that. Sometimes even Tide Pods or laundry materials we recommend be locked up as well. So the pilot really started that we did in May of 2020, and it was initially, at least at the Institute of Living, just for PHP, but then our director was like, we should really have this for all of the areas. So we really created more of a standard work process for all of our areas. So our colleagues down at Rushford, at Academy at Stonegate are also involved. Our PHP inpatient cares unit, the outpatient clinic, the Grace Webb School, also our testing department, and also our STEP or transitions clinic is also starting to be part of it as well. And on the inpatient unit, we actually took it a step further, and we are tracking all the different areas that are engaged in it as well. And one of the things that we added is adding a high risk criteria for those who are receiving it. So at first we were a little worried, like, how many lock boxes are we going to be allowed to have? Can it be every kid that we give it to? And now we do it with every single kid at discharge from inpatient and at intake at PHP. But for inpatient, we added if the teen had 2 or more attempts of suicide, more than 2 admissions to inpatient in the last 6 months, or scored higher than low on CSSRS at discharge, which is pretty rare. We were also tracking that and how many of those we were giving the lock boxes to. And then in June of 2021, I think that's the date, Ashley, that Natchog inpatient started, but if that's wrong, certainly correct me. So again, the requirements, what we did to include all these different sites is have a champion. So each area has a champion that is part of discussing any concerns that they had. They are responsible for educating their team. And so what we typically do is once an area is identified, they identify their champion and have everybody who will be part of the Lockbox initiative trained in the counseling on access to lethal means so that we can make sure that they're doing that and have that training. They also keep track of the lockbox supply. So I order it for all of the BHN entities with United Way. And then at the IOL, I hold all of the lockboxes in our area, and then people can come and get it as they need to. And then, of course, reminders and sending the demographic data on a monthly basis. And of course, including not only the lockboxes, but when was COM provided and the lockboxes were declined, including reasons why. And then another piece that we add is added is including documentation in our electronic health record that the comm was not only completed, but then if lock boxes were provided. So these are just our current departments and champions, and we just want to recognize them because we could not do this giant lockbox pilot without them, especially over the last few years and during COVID. And these are also the interested areas. Some barriers that we've had most recently is just staffing, with the impact of COVID or just not having enough staff, getting these initiatives going past, I would say, in the last year or so has just been really challenging. And also finding the time to make sure that they go through the comm training has been challenging. But once these areas are identified and up and running, they're able to operate pretty smoothly. So these are the numbers from May of 2020 to December of 2021. We haven't updated them for this quarter yet, but you can certainly see that the most lock boxes are given out on our inpatient units, which certainly makes sense. And then the second highest is our PHP and IOPs. And this is just for mostly the Institute of Living, and then Rushford, Natchog's numbers aren't included in here yet either. But we also try to track the total families where the comm was provided, as well as the total lock boxes, and then the total refused. The majority of the refusal, I think there's only been one or two that just say, no, we really don't need them, we're good, or they just don't want them. Most of them say, oh, we already locked them up, we already got the lock boxes from other areas, or we bought our own safe and we utilize that instead. So there's been, I think now we're over 600 in terms of giving them out in our areas. So our future steps, the pilot will end in September of 2022, so about 2.5 years later. And we did provide some feedback to Andrea and Jeanette at United Way, just asking for larger boxes at one point. And I believe that we'll start getting them pretty soon, just kind of seeing what they look like. In the meantime, we just continue to provide as many lock boxes as people need. And we also, our smart phrase, the way that we utilize the smart phrase is we wouldn't give the smart phrase unless somebody sent us their comm certificate. So that was something that we tried to monitor. But now we're just trying to make it for broader use, and then still trying to find a way to make sure that everybody gets the comm training. And then what we're doing, and Marissa has taken the lead on, is really trying to ensure that we can continue to do this work that we've been doing and make it applicable for all areas, including the adult areas as well. So we're working on identifying funding, as well as incorporating the comm training for each area as part of our standard work, and certainly making sure that that documentation happens as well. So does anybody have any questions or comments or concerns? I'm going to stop sharing my screen.
Thank you, Patricia. Jill from Middlesex. That was a great presentation. I'm wondering, how do those of us who are not on the pilot get access to this, or do we? How is that going to be rolled out or work?
Sure, I can answer that. So I thank you, Patty. That was wonderful. I really appreciate you covering so thoroughly what you all have been doing in the variety of settings at IOL, as well as across the Hartford healthcare system. It's wonderful that you're doing that. I'm sure you're helping so many families. And though no safe is really perfect, I mean, certainly firearm safes are probably the strongest safes that you can possibly get. It certainly is another barrier that buys time when it comes to decision making and tampering. And the one thing that we recently discussed in the Lethal Means Committee for the Suicide Advisory Board was, would it be helpful to attach the handle with like some type of lanyard to something so that it couldn't be removed from the location. But my sense is that the handle is not stable enough to sustain significant tugging or something. So, unless someone drilled a hole literally through the box and then attached some kind of cable, I guess that would be an option. But something that we're learning along this way, and hopefully we can identify boxes that maybe are a little bit more secure and could be somehow connected to a more semi-permanent site, so that it would be easy to know if it's been tampered with or not. So with regard to the initiative, the way that this came about is that, so my agency, Department of Mental Health and Addiction Services, receives state opioid response federal dollars from the Substance Abuse Mental Health Services Administration. And it made sense to, so in the prevention division, we have to identify a variety of different kinds of initiatives that we think are valuable to add to help to address opioid overdoses. And this was a perfect opportunity to essentially fund the United Way of Connecticut, that oversees the Connecticut Suicide Advisory Board Lethal Means Committee, dollars during the pilot phase, which Patty mentioned, and then for a 2-year period of time in the last couple of years, from 2020 to 2022, during the federal fiscal year, to expand on that pilot, engage more settings, because we only had 4 to begin with in the pilot, and now we have 21. And the 21, sorry, we have 18 systems and 21 sites, if I recall correctly. So essentially, it's open. If anyone's interested in still joining, it's all you have to do is email us on the website. Often what we'll do, for example, recently Cornell Scott Health Center reached out and requested hundreds of black boxes. We asked if they would like to join the pilot. And at this point, I think they felt that they weren't ready to commit to the other portions of the pilot. They were okay with handing out the boxes, but they weren't really comfortable with the management of the data related to, giving us feedback. And I'm not sure if they're doing counseling access to lethal means. But Patty, I think your point during your presentation, where you explain the importance of that this is really not something that should be just handed out without some discussion and safety planning associated with it, that they all 3 go together, the actual lockbox or even firearm locks. And we've talked about that recently a lot. And those are available. We can talk to folks if you are interested in also sharing those. But often the local police departments have those. But the discussion around counseling access to lethal means, safety planning, all really is important that it goes together as a package when you're talking to families. Patty, do you want to make some comments about that, or anyone else who's doing the project?
I can just share before I'm sure others have their perspective too, is that oftentimes the families are so great in talking with myself and colleagues of, oh my God, I didn't even consider over-the-counter medications. And the way we phrase it is, if you have pets or children in your home, you should really have everything locked up, because it might not be your kid that we're concerned about, but it might be their friends. And you should always know where those things are. And even, the sharps, we certainly talk about firearms as well. And even like the laundry detergent, Tide Pods, bleach, things like that. We think about all the different things, which can be really important. And we, in our program in child and adolescent day treatment, in our PHP, IOP, and EDT, we actually say it's a requirement for your teen to be in our program. And we're always saying, we're okay to be the bad guys if you're hesitant about how your teen responds, but we have a conversation with the teen to try to understand where they know where things are. And then we also have one with the family. And then we bring them together and have a conversation together about it and say the requirement is to lock these things up just for safety. And it's definitely been very helpful with our high acuity and trying to restrict those means, especially lately.
I can speak a little bit to how NatJog does it on the inpatient unit too. We really roll it into our overall safety planning conversation, because we also use a safety plan tool that we build with every patient before they discharge from our level of care. And the nice thing is that that's a living document that lives within Epic. So then when they transition to, say, the IOL's ambulatory programs or our own ambulatory programs, that lives within the problem list in Epic. So they are not necessarily creating a new safety plan every time they go somewhere. It can just be updated, which is nice. So our discussion and our specifically around access to lethal means is done incorporated with that safety plan document, which is typically built right into the family sessions that are had prior to discharge of what specific concerns do we have around this case, around access to specific things at home. That includes locking things up, reducing access to other things, taking into consideration if they came in for a suicide attempt, what the specific means were for that attempt or other past methods that have been identified, to then really try to tailor it to that specific child of what things we really want to target to be secure in that home and in other places they may have access to, like if they go to grandparents' houses regularly or different things. We actually have a case right now, very, very challenging. The child is actually from Tokyo and was over here for a boarding school situation. They are incredibly high risk. And so the parents are coming today to pick them up to bring them back to Tokyo. And the lock boxes, we have 2 for them. We have one to carry with them on the plane with PRNs in it to try to keep her calm throughout the plane ride. And then also a 30-day supply of medications, knowing that transition internationally can be a little bit more challenging than to any of our ambulatory programs. So they also have one that will be locked and secure within a locked suitcase that will be stowed underneath the plane in the baggage area. So we've incorporated them in a lot of our cases to really decrease risk.
Yeah, I would agree with everything Ashley and Patty shared. I think the other piece to this that they're pointing out too is that it's not just one conversation, it's continual conversations. It's revisiting, how is this plan working? What changes need to be made to support the safety? You know, and I think with adults, this becomes a little bit more challenging, you know, helping to develop autonomy and independence in safety, but also means too. So it's definitely probably looks a little bit different as an intervention, but so important across the lifespan to have these safety measures in place.
Yeah, we participate as well, and we're often just a snapshot in some of these kids' lives during their crisis periods. But to be able to hand them a physical thing that is not only part of the plan, but also kind of a reminder, hey, by the way, you have to do this. Versus, you know, here's a certificate to go pick it up, which may or may not happen, or even worse, you should go buy this, which then they say, you know, he's not going to get into the meds anyway, I'll just hide him. And we know that doesn't work at all. Patty, do you think you could share with the group not only the PowerPoint, but if you have like a 1-pager about your program and how you guys do it, or certainly I'd be really interested in the smart phrase you guys use so that I can put that into our system so we can start using that. I believe we have something now, but it's probably not as good as yours. And then do you guys have the data for the whole program? And will that be available at any time soon?
Sure. So I saw Patty nod. We have the data for the the entire state, but Patty, I guess, are you talking about maybe the protocol? Are you thinking, Steve? Is that what you're asking about? Like how they do it, like a 1-pager or a recommended protocol?
Yeah, something like that. Just a summary. Just you know, because you guys have the fact that you require the comm training, I think is great. We use the means matter from Harvard, but it's different and less comprehensive, but fast and free. So that's why we use that. And so I have to look at the comm training again. But the other offer I'd like to make is if you guys have that data, we have some really strong connections with UConn's GIS, Geographic Information Systems team. And they may be able to analyze that for you in a way that most of us couldn't do. So let me know when you get to that point if that's something you guys are interested in. So we may be able to see some interesting trends or not. You know, it's hard to say what would come up as interesting, but certainly might be helpful in analyzing the program before you guys look for more funding.
So I would answer your question about the data first. I'm sorry, was there someone else speaking too?
Somebody has their hand raised.
Oh, I'm sorry, I didn't see that. Can you tell who it is? I can't see everybody.
I can't
Oh,
either.
Anastasia. Hi,
Yes.
Sorry, go ahead.
Hi, question for you. So this is very interesting. I'm interested. We've been giving lock boxes out like ever since, you know, COVID, like right before COVID, like when the whole entire epidemic for when we got money from Demas for SPIFRX dollars. We went to the real estate offices and, you know, for whenever somebody had an open house, we educated the real estate agents about, you know, giving out lock boxes to the individuals selling their home. So this is very interesting that you're doing this for younger kids. And we recently received a grant through DPH for suicide prevention. And we are working with United Way on this as well. And I was wondering, is this a conflict of interest if we were to participate in the pilot with you? Because this is something that, you know, those, you know, they can attempt suicide by these specific means that we're trying to use the lock boxes for. So I just don't want to like go into like, you know, one fund of money and another fund of money. I just want to make sure that I'm able to participate, which I would love to.
That's fantastic, Anastasia. I can answer that question too. And I'm sorry, you weren't here when we were doing introductions. If you don't mind introducing which local health group you represent. I can't remember if it's department or district.
Torrington Area Health District.
Torrington. Okay, fantastic. So I'm kind of like the point of contact for all these things.
Oh, okay.
So I'm one of the project directors on the CDC grant that you're funded through United Way for. And I oversee the state opioid response grant that funds the lock boxes. So there's not a duplication. We would encourage you to participate. Certainly, we fund the United Way with these lock boxes to disseminate to anyone who's interested in participating in the broader project. But not only that, anyone, if you go onto the site, and I'll show you this in a moment by sharing my screen, you can request lock boxes. So even an individual grandparent can, you know, and they do, believe me, we get them almost every single day, requests from individual family members who are concerned about the kids in their households. They don't want their kids getting into their own medications. You know, they're getting, it's not just related to the mental health need, but they really just are looking for opportunities to reduce access to, you know, unauthorized users, as we talk about often with regard to lethal means. So, but then when we see that individuals are requesting large quantities of boxes, that's when we especially will approach them and say, would you like to also participate in the project? Because they may be a particular site that is well positioned to also perform lethal means counseling and safety planning. And sometimes they accept and sometimes they don't, but we never withhold boxes.
Are you talking about the boxes from the clearinghouse, the CT clearinghouse, those that you can request?
No, they're actually through the state site. So let me share my screen at this point, and then that should provide some additional clarity. So this is also given, like this is a zero suicide learning community. We also have other committees under the Suicide Advisory Board. One is the Lethal Means Committee, and they really are leading this initiative and report the data to me. Going back to your question, Steve, and offer, the data that we have may or may not be able to be arranged in the way that you're thinking, because we collect data by site and also demographics of who they are serving, but we don't collect the residents per se, like zip code or anything like that. So maybe we can talk offline further, you know, in further detail about what could or couldn't be done with what we have. But the good news, before I do share my screen, is just recently in the last week, we did hear that it's very likely the state will receive additional state opioid response dollars. And I wouldn't doubt that this is one of the projects that we would like to continue. We will need to extend the existing contracts once we get approval for that, but we are still waiting for really the formal acknowledgement from SAMHSA about that.
And you did say that you are able to share the data from the areas that you are working with for demographics?
We have demographic data related to the service sites. So for example, you're in Torrington. I can't remember in the Torrington areas.
Had McCall
What's
written-
that?
You had McCall written on there.
Yeah, McCall might has some data that they've submitted. So yes, you're right.
Okay, okay,
Mhm.
excellent.
Yep. And yep. So with that said, let me share the screen. Hopefully this works well. Let me know if you can see what I'm doing. It'll just take a moment. Okay, I see that's all right. So what I have pulled up in advance just to share with you is a couple things. So why don't we first actually go to the materials order page of the state suicide prevention website. Can you all see my screen?
Yes.
Okay, great. So hopefully you can see this. So this is the preventsuicidect.org site for the Connecticut Suicide Advisory Board. When you go to the site and you click on materials, you're going to see a variety of different options. And one of them is to order materials. So on here, and all of these are free. There's no cost to any of these materials. So you just need to complete the information above, and United Way of Connecticut manages the distribution of our materials in collaboration with other entities that we contract with. So you can see there's a variety of different kinds of things on here. And if you scroll down, as you start to scroll down, you'll see additional materials related specifically to lethal means. We have a variety of firearms materials, a variety of medication materials, and when you do request the lock boxes, which are right here, you can request additional materials to come along with those so that you can distribute them together if you're part of the project, rather than going through the site to order everything. Once you make that initial connection with us that you're interested, then what Jeanette will do, Jeanette Baker at United Way, is will manage, how many boxes you need and also print materials to go along with that. Something that the Lethal Means Committee has created recently is also this Safe Proof Your Home brochure, which it would be an excellent brochure also to share when you're doing counseling access to lethal means, and it goes through different areas of the house. That committee created that, and it's available in print. The other thing that I should share with you is that, let's see, it's not on here right now because we're in the middle of a reprint, but as you can see, we have similar to these sticky note pads that you can kind of see here on the right. This is related to when police are responding to, or the medical examiner's office are responding to a loss. We have a similar sticky note pad for the Columbia Suicide Severity Rating Scale, brief screen. And what's happened recently is we had done an order. It's a tear-off sheet, that's sticky note pad. You can write on it, and the police and CABLE, the Connecticut Alliance to Benefit Law Enforcement, has requested all of them so they can distribute them during their CIT, the Crisis Intervention Team trainings, to police. So we gave them our entire stock and we're reordering. And what's good about that, and why I'm sharing it now, is that the initial order stated that it was for law enforcement at the top, and it has triage points on it. But the new one won't have specifically that it's law enforcement, because it is certainly transferable to other areas. Anyone can use that, and certainly it's important as a proceeding activity if you're going to be needing to do safety planning to do some screening, right? So that's why I'm sharing that with you now. So soon you will have access to those tear-off sheets that we encourage you all to use if you especially are not in front of a computer when you're doing the Columbia. So going back, I will also just share, so you can see again, there's other materials up here. One thing I should mention too, just a reminder, that the Gizmos Possum book for kids, and these are links to, they also have, in Connecticut, you can get books for free. The plushies are at cost. So if you wanted to purchase some and distribute them to folks that you're working with, that's fine. What I want to remind folks about is that this book is basically the safety plan in a narrative format that is was initially developed for kids of elementary age, but we have found that all age groups really are responding well to it. There's a mental health plan in the back, which is exactly the safety plan, the Brown and Stanley safety plan. Both Brown and Stanley are aware of the book, are supportive of the book, and they love Gizmo. When Dr. Stanley came a few years ago, she wouldn't let him go all day long when we had a presentation that we were doing for the state. So what I will also share is, so get those books for free and give them out to kids and do safety planning with kids. The safe storage site page, this again has the link to the comm training there. You can link to that. I'm going to show it to you in a second. Also, there's a lot of more links here to information on firearms, and then this order will link you to the other page I just showed you on different substances and safety around that, and additional information around means matters and safeguarding your home, even parking facilities and such. That Lethal Means Committee is very busy. They've been doing so much. And in fact, I just found out the Department of Transportation is about to do a press release on all of their signage they've been posting everywhere across the state. One thing that I'll share with you is that, especially around the firearms component, these two, I've shared these in emails to you all recently a few times. It's important that you be aware that there's a general public and a healthcare professionals brochure that the Connecticut Coalition Against Gun Violence created, and that if you're interested in accessing those resources, those brochures are linked here. And then going to the counseling access to lethal means. So if you clicked on that link that I just showed you from our safe storage area, it'll link you to this Zero Suicide educational page, and it talks about what counseling access to lethal means is. It's a self-guided training, and you just have to, there's no cost to take it. And as Patty mentioned in her presentation, I believe you require that before dissemination of the lockboxes occurs, that people do attend this training, do participate, correct?
Yes.
Thank you. And then if folks aren't already familiar with the safety plan tool, that's also accessible from our website. But the Stanley Brown safety planning tool is on this web page, and there's guidance around how to use it, training related to it, and et cetera there. There's no cost for accessing this either. So hopefully this tour has been helpful to you all. And I will certainly, when I send out the recording, follow up with sharing those links again with you all, now that they may have more context versus just sending them out in prior emails. Are there any questions?
That was really helpful. Thanks, Andrea.
Sure.
I'm going to put in a huge order by the end of the day. I'm just kidding.
Thank you.
Oh,
Say
Sade, you're back.
One quick
Hi,
question.
Karen.
Andrea.
Oh,
It's
yeah,
Karen.
sure.
Yeah,
Yep.
just one quick question. Have you had a lot of health department interest in it for like this, working with the school counselors that come to them and say, look, I have somebody, and we've talked to the parents?
I wouldn't say, no, health departments really, and there are a couple health departments on right now, and those health departments are very involved in existing grant activities.
Yeah.
But what I would say is that we definitely have noticed that the health departments are not as engaged as, at least not in general as a whole. We do, through the years have had some health departments receiving gatekeeper training or becoming trainers to train others. And some of them have been active in the Suicide Advisory Board for a number of years, but we're trying to engage them more so through these current efforts and current grants. And we're so grateful that you all from the health departments and districts are here today to join us for this conversation. We did put in contracts that we would want them to participate in their regional suicide advisory board and the suicide advisory board, but we didn't require you all to be here today. So we're excited that that you're here on your own interest. So I think what I would say about working with schools, and I think that this is really important for the school-based health centers, and I don't know if Melanie is still on, but I'm on the school-based health center advisory committee, and Melanie is connected to that as well, as she introduced herself. I think one important opportunity, if we're looking at the future, is I would really like to, in this next iteration, continue to expand what we were already doing, but really start to focus on school-based health centers and like FQHCs that we haven't successfully connected with yet. And I don't know that schools otherwise are necessarily in a position to do the extensive work that's required that Patty's describing and that the others are describing that they're doing. I think that it's possible mobile crisis might be in a better position to do that. And I know we have quite a few mobile crisis leads on today, and also Erica, who oversees our adult mobile crisis for DEMAS. Do you have any thoughts about the capacity of mobile crisis to do this kind of work? Just in general, asking the group.
I'm back. I heard the tail end of that. The capacity, say more to do what? Which part of it?
In general, thinking, let's just talk about an example for a minute. If a child is identified at the school, so the schools are being prepared at this point to, the schools are being prepared, to update their policies and procedures, do planning, suicide prevention, intervention, and response. Like there's a lot of work happening around that. One of the things that they're doing is adding the Columbia screener. If a child is identified at being potentially in a crisis, that this is one of the things that they're going to be doing or encouraged to do. The next step in the protocol would be reaching out to a mobile crisis provider. And, for you all at CHR, as an example, you'd be responding to the school. The school, I don't know that they're really in the best position to do the further assessment, counseling, access to lethal means, safety planning, and lockbox dissemination or things like that.
Right.
Is the mobile crisis provider, and especially with the coming of 988 soon, I mean, would you see that this is within their scope of capacity?
Yeah, I mean, we'll see, because if you build it, we'll get a better sense of the volume. I would say anytime a school does training around suicide, we ask them to give us even a little heads up, because it usually means we'll get a few calls, from kids who they've screened, through the actual classroom, discussion. And it's perfectly fine. Like, we would want to see those kids who may be, at low risk even, who may not have ever shared, before having ideation or thoughts. Like, those are definitely the kids we want to see. I guess I'm not sure how many of those there are. I think we have some, research from the Department of Education. It's what I could see the little number. I think it's like really 3 out of 10 kids, maybe. I don't want to say it wrong, but, are depressed and, would benefit from a mental health intervention. So if you imagine, 30% of the kids in every school are struggling, that seems really high to me, in terms of mobile crisis being able to tackle that. But I never want to say that we would discourage or not even try, to see or to help kids. And the system will just have to continue to build to respond to that. This isn't a good time to ask me because we're down staff, as most people are. But I keep saying to, the director, imagine there's everybody here that we need, you know, and we're going to overnight at some point, probably in the coming months, certainly by next fall. So there's more capacity and more funding coming our way. And we're looking at federal grants to hire more staff within the mobile crisis team to do stabilization work. So the future of mobile crisis is expanding by the second. And so I'm trying to imagine a future where we really could be, you know, available to kids in the way that you're asking. It's just a little bit far in the future. And we've never really had people do the screening to the extent, you know, that you're talking about. So we will just have to see, you know, what will come of that.
So meaning that they do the screening with the Columbia, but they're not able to do the next step of safety planning with counseling access to lethal means and all. Is that what you mean?
Yeah, I mean, I don't know that they've, you know, developmentally they can do the screeners now, right? Like that took years to implement. I don't think it's not possible, because the other thing that I'm hearing is mental health funding for schools is on the rise, and you know, there's a need to have more professionals trained for their students. And so I wouldn't say they couldn't do it. It would help to have more partners using the same interventions and tools. And, you know, a lot of the school professionals are as educated as my staff. They have, you know, master's degrees, clinical social work or psychologists. I'm not concerned that they don't have the ability to do safety, you know, planning. It's the typical thing is that it's not their role, you know. So the systems change is for the schools to see the role of the school social worker and psychologists more expansively. It's not really an issue that they're not credentialed.
Mm-hmm. So I do wonder, you know, at one point in the crisis system, I mean, other than the obvious healthcare providers, who's best positioned to do this kind of work? Because when we're thinking about this, all links to like the 988, you know, coming of 988 crisis service system, where we have schools connecting to mobile crisis potentially connecting to 23-hour urgent care, crisis care centers that are yet to be developed, but are on the, you know, planning vision, and we're looking for dollars for that, and hoping to divert unnecessary admission to the EDs and things like that, and really increase direct access to beds and such if we need to use psychiatric beds. So I'm wondering what people are thinking about that, because like where along that crisis service system, other than where we're doing this work right now, where does it fit in the context of all of that?
I can share a little bit around NATCHOG's plans for that too, because we used to have an open admission plan where people could have like a walk-in admission process. We are in the process of starting that back up again for this exact purpose, because we know going through the ED is incredibly challenging. There's often lengthy waits. It's not a good experience. We know trauma-informed care is not as prevalent in the emergency room setting as it is in our units. Which is another initiative we want to take on at some point. But in the interim, we're in the process now of getting that back up and running. That'll particularly be important for our ambulatory locations where we know we're sending a kid to the ED from one of those options. And rather than doing that, then being able to kind of skip that step to come right here. It's also going to be really inclusive in terms of like financial limitations as well, knowing that ED visits can be costly, especially when they're stuck waiting for a bed for days, when we could just potentially take them right to us and kind of bypass that step in hopes of getting them faster treatment here, again, to just support for anybody who may be avoiding that just because of the cost associated with it. So we're in the process of that now. I know there's a meeting happening for it today. St. Vincent's is already doing this too, so it's something that's kind of being looked at across the BHN from my level of awareness. I'm not sure about the IOL, Patty or Marissa, if you know anything about that, but I know that's something that we're hoping to get back off the ground pretty quickly.
Thank you for sharing all of that, Ashley. I know that that's a huge, you know, goal out of DCF and DMS is to make that all happen. We actually have what's called a Tti Grant. It's like a technology grant that's going to help us also advance the mobile crisis access to a bed registry. We already have that for DMS, but we don't for the kids, and that will help that significantly. I don't know if Erica is still on. Erica, are you there?
I am. I'm here.
I'm wondering if you have any thoughts on the adult side
Mhm.
about all of this
Yeah,
and capacity of mobile crisis to do some of this.
Yeah, I mean, obviously we're with adults and folks 18 and older, but certainly one of the things that mobile crisis clinicians do is safety planning. I don't think there's a formal type of safety plan, but there's certainly, connection with follow-up services. And there's actually a requirement for there to be follow-up with individuals that they are going out to meet with for a crisis assessment within 48 hours. So there is sort of that component. And I know, as Amy mentioned, there's definitely a staffing, a challenge with staffing and whatnot, but CMS is also exploring and encouraging folks. And in fact, we've had some of the mobile crisis teams hiring peer support specialists. And the way that we envision that role is for them to really have a potential and ability and a focus to do some of the prevention and postvention work of follow-up with folks. And so, there's also referrals to open access hours. Some of our mobile crisis clinicians are also part of their LMHA or whether state operator PNP, they're also part of the assessment center. And so they're able to make, referrals for an intake assessment and do some of the additional, sort of screeners and that sort of thing. So, and I know Lisa Zerulo, who is also part of evidence-based practices in Grant, she oversees our outpatient programs, and she's sort of working on getting a sense of, those open access hours and locations and getting that up actually on the DMS website, which we don't currently have.
That's great. Thanks for that, Erica. So I think that there are some great opportunities for next steps. I know folks were sharing wonderful ideas. I don't know, even with additional mental health support, I'm not sure where the schools will go with that. There's a long way to go with that. I know I heard from the CEA yesterday, actually, they had reached out to engage us in supporting some of the I think it must be that huge children's mental health bill, the HB 5001, that includes the recommendation to add mental health clinicians to schools. So I think there are a couple of different points along the system, whether it's for children or adults, it sounds like, where we could be doing more of this. So having resources available at for different levels of readiness, I guess, depending on which provider you are and what your system looks like, is important, in making sure that folks understand that this is kind of a recommended package deal for evidence-based practices, that they go together, like you said, Patty, and sharing what you described. And I'm sorry, I'm having trouble keeping track of the chat. But sharing kind of an approach, that whether it's a formal protocol, but a recommended approach to about how to use these in a coordinated way, and to maintain it from that champion perspective, that point of contact, that role that you play and a lot of you play, I think would be very helpful. And we can certainly post that to the site as well. Any other thoughts?
I was just going to share too, along the lines of this conversation, our web schools really for the first year this year are actively engaged in creating a suicide prevention committee, which I think will develop into a suicide prevention task force, which is kind of consistent with the model school district policy. So I think upwards of 60 plus staff, school staff, a lot of teachers and support staff went through a QPR training. And so it's both emphasizing the ability to identify, but then also what to do next. And that's where those, like you were referencing, Andrea, those protocols really, really come in place in terms of what's the care pathway essentially in the school. So I'm looking forward to further developing that across the web schools just to start.
That's great. I don't know who did all that QPR training, but thank you. I know you have quite a few trainers in your own system.
Yep.
But if
Jennifer,
you need, oh, great.
Our director of well-being at HHC.
That's wonderful. So just a reminder that the Regional Suicide Advisory Board points of contact at, so for in the IOL area, it would be, Amplify. And Ali Naidu, who's often been a part of this conversation and is also a member of the Suicide Advisory Board. And even Tom Steen, too, who co-leads the Suicide Advisory Board. They've done a ton of work on working with schools. Each of the RSABs and Tom have been doing a ton of training and work through the years in helping school systems develop their suicide prevention, intervention, and response plans. So if you know schools that are doing this work and feeling a little frustrated because they don't have enough guidance or support, or just looking for more of that, then the regional suicide advisory boards are excellent places to connect them with. And certainly Tom is also a good contact. And if you can't remember all that, just have him contact me and I'll make the connection myself. So I think, unfortunately, I think two of the folks that made comments and maybe placed questions in the chat, I think Anastasia had to jump off and Sade was here for a little while and then she jumped off. I don't know if folks are looking in the chat, but there's a comment about statistics show us that an alarmingly high percentage of folks who end their lives have seen physical health practitioners within 30 days. Suicide prevention is everyone's responsibility, and that's for sure. And as we were talking, I've been making some notes as, we always want to expand on the existing activities that we're doing as we go into the next phase of funding. And so I think it's important that we do some outreach to school-based health centers, FQHCs, doctors' offices, maybe do some piloting in mobile crisis on the child and adult side. Maybe there's a higher level of readiness in some sites. And I know staffing has been challenging across all age group for all the entire system, but we'll see, who might be in a better position to do some of that to see how it could work. Any other ideas? No. Well, if you think of any, you know where I am. You know how to contact me because I email you, so you can just email me back. And with that, I'll just remind folks that we typically will go somewhere between an hour and a half. We don't need to go to 10:30 if we don't have other things to discuss necessarily. But I would ask if there are any updates that you'd like to share, and then I'll just talk to you a little bit briefly about the next meeting that's coming up in May. Any updates that systems would like to share? No?
I can share one, Andrea. Myself, Marissa, and a few of our colleagues will be presenting at the AAS conference in person in April on our postvention work in our system. So we'll report back out on that in May.
That's fantastic. That's great to hear. So Chicago, here you come, huh? They better watch out. I will be attending through a virtual, so let me know when that session is so I can participate virtually. Congratulations on being accepted.
Thank
Congrats,
you.
Patty.
And thank you, Patty, for highlighting that. I don't think it's my head of things. I know there's updates, but of all the updates, what do I pick?
Along those lines, I just wanted to share, we had an abstract submitted and accepted to our Pediatric Academic Society, which is our national meeting focused on pediatric research. And so we'll be presenting in Denver in April. So that'll be fun to share our progress and hopefully convince my colleagues across the country that screening for suicide in the emergency department is a feasible activity and produces some pretty fantastic results. So we're still humming along at about a 17% positive rate for kids 10 and older, which is not great, but great that we're identifying them, and we're up from 5 to 6% for medical kids.
Wow. Thank you, and congratulations, Steve, for getting in there. I think that's a really important message. I think one thing I would love to see, if we would, as a group, could promote more is the screening of all folks coming into the emergency room, regardless of presentation for behavioral health or medical. I was explaining yesterday during our governor's challenge to the folks that are connected to veteran and service member suicide, that right now that the Joint Commission's requirement is for behavioral health presentation, not medical. And that's something that, given all the data, shows that there's justification for, certainly for both. And that you all, as far as I know, are the only ones doing that right now in the EDs in Connecticut. I don't know if any other hospitals have expanded that, the screening process to medical patients
No, I don't,
as well.
I'm not aware of anybody doing true universal screening, which, it's preaching to the choir with this group, but that's the only kind of screening that makes sense to me. If you come in with a behavioral health chief complaint, we already know you're at increased risk of suicide, so might as well skip the initial screener and just go right to the risk assessment. And so, I think it was a good effort. I think it was met by a ton of resistance by some of the Adult Emergency National Society. It's called Emergency ACEP, American College of Emergency Physicians, really said that was not a feasible activity, but I'm determined to prove them wrong. We also, some of your EDs may be struggling with the new legislation that requires we hand out information on community-based resources, and specifically community-based resources for that individual. And DCF has posted a website that has a bit of a clearinghouse. Unfortunately, to print that out and hand it to a patient often requires us to print about 7 to 12 pages of information that is not likely to be used. Unfortunately, it's a little difficult to navigate. So we're working with some folks out of UConn, actually, main campus, to develop a much briefer version of that we'll share when we have it. And I'll have a QR code on a magnet that brings you to an introductory web page that's much easier to read as a parent. And then that page will have links to other resources, including the DCF one if somebody wants to go to that actual search engine. But we went through it, and it's we'll just say it has its challenges, including wrong phone numbers and misspellings and just tons of duplicate listings. Wheeler must have like 50 listings on there. CHR's got a ton of listings. It just because you have sites, so they list every single site, which is probably not the way to access resources at some of these larger providers. So we're working on that as well. So some good glimmers of hope. I think that the best one I've seen, we actually just shared a huge, what I'll call a data dump. We transferred comprehensive data from our EHR to Rob Asseltine and his folks. And many of you know who Rob is. He's a researcher out of UConn. And so we are working on health record database algorithms that could identify folks at risk for suicide, so that we could target them for specific screening. And computers don't sleep, and they also don't have to come into the ER or go to a clinic or show up at school or anything like that. So that to me has been the most hopeful method of identifying folks, if we can actually figure it out. So more to come on that. If we make some findings, I'll see if I can have Rob come in and give us an update on that too, because that's a really cool concept to screen without screening, basically.
Mm-hmm. Yeah, I know we wrote a grant together for that, hoping to get it for Zero Suicide back in 2020. Did he get a different funding stream for that?
I think he did. He got some stuff in from NIH. We put in another one, but that wasn't funded. But we're going to resubmit, and hopefully that will get funded.
Awesome.
But Rob's always got resources.
Yeah, it would be great to hear from him on this. I know, like when he tries to explain it to me, I just don't get it. I mean, I understand the
Right over.
intent, but the way he
Yeah.
describes the algorithm, it's just more than my brain can take.
Yeah, I think that
Um,
the simple version is the computer looks at all the data and
Right.
tries to figure out who's at risk and who's not.
Yeah. So basically, it's not even about screening. It's all kind of what's in the EHR and kind of creates almost like a profile of individuals at risk is the way I would describe it, right? And then it presents like it will all of a sudden flag that this person is at high risk. You should probably connect with them around, do a screening and assessment on them because they're coming up as a high risk individual for whatever reason based on the algorithm. It's pretty cool. So
Yeah, it's really neat. And it never rests. So it's always going in the background.
right.
So we can continually be screening people.
Yeah. Quietly, kind of
Yeah,
third
very cool.
party in a way.
It's a little Big Brother-ish, but it's
Yeah.
well intentioned.
They're already in the system. So, you're
Mhm.
already in the EHR. So that's really great. Fantastic updates. Any other updates?
The only one I have is maybe with you and Steve, and we could talk about this after the meeting. There's a little bit of funding from the past GLS that was still out there. So if either Steve or Andrea, you could talk after this meeting or by email or even stay on, that would be helpful for me.
Sure. I
Okay.
can stay on.
Okay.
Anybody else? I'll just really quickly share that, things are moving along with 988. I mentioned a little bit during our discussion today. What I would just want to share with you all is that a reminder that what's happening this year is really making sure that all of the infrastructure components are up and functioning properly, the telecommunications are functioning properly. Where our goal is to continue educating people about kind of managing the expectation of what will happen when they call this number. But they don't want us to actively promote the line until next year, once they really have a chance to test its functionality. And so if you're not seeing things and you're wondering, is Connecticut doing anything? That's why. But we are offering, Erica and I and other colleagues of ours through our collaborative of the DCF, DMIS, and 988 Coalition have been doing a lot of educational presentations to folks and groups. So if you have parties that you would like to receive that presentation on what 988 is, why we need it, what's happening to develop the crisis system, because I think what's really important to remember is it's not just the 3-digit number for call, text, and chat, but it really is the entry point for the entire crisis service system. And so it's not just a matter of getting that call, text, chat, telecommunication component ready. It's literally getting the entire system ready so that as people start to enter that doorway, that we can respond appropriately based on their needs. And so that's what's happening across the United States. And every state is very different from the next one. But we're pleased that we're moving in the right direction, and we definitely have some solid foundation solid foundational components already in place, especially with mobile crisis. I think the biggest challenge lately, as Amy mentioned today, has been the workforce. We've lost a lot of folks. The retention and hiring has been very challenging for everyone. As you all know, in the healthcare system, I know you felt it as well. So, and I really appreciate all that you do in your work. I know you've been stretched pretty thin this past couple of years, especially with the workforce issues. And I'm just so grateful. Oh, and I see Walter joined us for part of the conversation. Hi, Walter. And Kathy Chapman, I missed you both earlier. I don't know if they're there now. So any last comments before we close the meeting?
Thank you for so much you guys do, you and Patty and the other committee members.
All right. Well, with that said, I'm going to stop the recording. And what we'll do with the recording is share it with folks, but we've been also